Hi, my name is Dr. Pedro Ramirez, and I'm a professor in gynecologic oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas. This year at the BGICC conference, I will speak on the updates on criteria for patient selection and surgical management in advanced ovarian cancer. This will be a conference where we will be discussing a number of topics as it relates to selecting the ideal patients for surgery when considering surgical cytoreduction in advanced ovarian cancer. There are times when obviously we need to make a decision as to whether what's best for that patient will be neoadjuvant chemotherapy or surgical cytoreduction. And therefore, I will speak a little bit about the studies that have led up to this concept of the selection of patients for chemotherapy versus surgery. And then I will also focus on the assessment on tumor resection probability. In other words, how do we select those patients who are ideal candidates for surgery? I'll talk about the structured radiology report that we have developed in the Department of Gynecologic Oncology at MD Anderson Cancer Center and how this structured radiology report helps us, in fact, determine how to proceed with the management of such patients. What is the role of the imaging studies, particularly focusing on PET-CT imaging? And I'll discuss how we use that in this setting, as well as a laparoscopic scoring. As we know, many institutions actually have used the laparoscopic approach to determine whether a patient is an ideal candidate for surgery, and we'll speak as to how we use that as well. And then briefly also talk about the peritoneal carcinomatosis index that in many institutions is actually routinely performed, and I'll talk about some of the advantages and disadvantages of that index scoring system. I'll speak about surgical complications and nomograms to predict likelihood of surgical complications, as well as the surgical quality indicators in patients with advanced ovarian cancer. Certainly look forward to seeing you at the meeting. And again, it is an honor to participate. Thank you. Well, among the highlights, first talking about surgery versus neoadjuvant chemotherapy, I will be speaking about the fact that there have been a number of prospective randomized studies evaluating neoadjuvant chemotherapy versus upfront surgical cytoreduction. And each of these randomized trials, the EORTC trial, the CHORUS trial, the Japanese Clinical Oncology Group trial, as well as most recently the Scorpion trial, each has demonstrated that there is no difference in terms of disease-free survival or overall survival when comparing neoadjuvant chemotherapy versus surgical cytoreduction. So obviously we are now awaiting the results of a very exciting trial that has completed accrual already. That is the TRUST trial that also compared neoadjuvant chemotherapy versus primary cytoreduction. This is particularly in the setting where these are skilled centers, skilled surgeons, and centers with high volume, and therefore, obviously, we're looking forward to the results of that study as well. As it pertains to the patient selection, I will speak with regards to the structural radiology report, and this is important because in many centers, there's not a specific outline with regards to the radiological findings pertaining to patients with advanced ovarian cancer. And I want to highlight specifically the structural radiology report from MD Anderson Cancer Center, where we have asked the radiologist to specifically detail to us where we find evidence of disease in the setting of advanced ovarian cancer for us to have a much more accurate determination as to which patients are ideal candidates for surgery. In addition, I'm going to speak to the updates of the Fagotti score. In other words, the laparoscopic assessment score, how we use it in our institution. And certainly this is a strategy that we considered essential in order to determine whether the patient should undergo primary surgery versus neoadjuvant chemotherapy. I'm going to speak a little bit about the LAP-OVCA trial, which is a prospective randomized trial to evaluate laparoscopy to predict the results of primary cytoreductive surgery in advanced ovarian cancer. And then briefly, as I mentioned, talk about the peritoneal carcinomatosis index. which is not commonly used in many institutions, but certainly many advocate for this index. So therefore, I'll speak as to what are some of the pros and cons of that particular approach. I will speak also as well on the surgical complications and how to predict potential surgical complications in the patients undergoing cytoreductive surgery for advanced ovarian cancer. And in addition to that, speak briefly on the quality indicators for advanced ovarian cancer surgery that were published by the European Society of Gynecologic Oncology in the 2020 update. So certainly many points of discussion in terms of the conclusions and the points of consideration. Certainly we recognize that patients with a poor profile in terms of tumor burden should undergo neoadjuvant chemotherapy. Trials evaluating operable patients receiving neoadjuvant chemotherapy showed no difference in outcomes as it pertains to disease-free survival and overall survival. We recognize that the quality of the CT scans vary among centers, and therefore a radiology structural report is highly advocated, and that the laparoscopic assessment may increase the likelihood of having an optimal cytoreduction defined as R0 cytoreduction in the setting of advanced ovarian cancer. And then certainly, obviously, that we await the results of the TRUST trial to determine further evidence with regards to how to select patients for surgical cytoreduction versus neoadjuvant chemotherapy in the setting of advanced ovarian cancer. I think the take-home message is that we need to evaluate each patient individually, to do a thorough evaluation by imaging studies and potentially by laparoscopic assessment to determine which patients are ideal candidates for neoadjuvant chemotherapy and which patients are ideal candidates for surgery. So I think it's a message about individualizing care and determining based on all of these criteria what is best for our patients.